Assalamu alaikum everyone. As promised, antibiotics lecture. I want to give some credit to Online Med. They detail a whole lot of this stuff. If you have any time to check them out, Online Med is the best. But quickly, antibiotics basically started at penicillin. Penicillin is the very first antibiotics, as they say. But I want to point out that penicillin is not used anymore. Penicillin is only used if you suspect your patient has syphilis. If they do not have syphilis, never ever use penicillin. Okay? And the antibiotics are basically structured around, is it a gram-positive infection or is it a gram-negative infection? Let's just go up the gram-positive side. So in gram-positives, you basically worry about staph or strep. Now, in the lab, there is an antibiotic called methicillin. Methicillin is not used in practice. You should never ever use methicillin. Do not order it. It's not used. Methicillin is only in the lab and is supposed to detect, is it a MRSA infection, meaning it's methicillin resistant, Staph aureus, or is it a methicillin sensitive Staph aureus? Because if it's methicillin resistant, it is called MRSA, and this is the big bad wolf, the very worst of the gram-positive bacteria is MRSA, and we have to use big guns like vancomycin. So methicillin is only used in the lab. Remember that you don't treat anything with methicillin. You basically want to know, is it MRSA or MSSA? MSSA is the friendly MRSA, the methicillin sensitive MRSA, or methicillin sensitive Staph aureus. And then if for some reason you can't use vancomycin, then there is another option, which is linezolid. And linezolid is just very, very, very expensive, but it's very useful in treating MRSA if you are unable to use vancomycin. All right, let's just quickly jump to the gram-negative side. In the gram-negative side, I know they speak about amoxicillin and ampicillin, and you know that you treat strep throats and things like that with amoxicillin. But I want you to remember that amoxicillin also treats gram-negative infections. In fact, it treats most of the gram-negative infections. So for now, we'll think about amoxicillin and ampicillin as gram-negative bacteria or antibiotics, okay? And then I want you to know that in order to get amoxicillin to be broad spectrum, you have to add the beta-lactamase. The beta-lactamase for amoxicillin is clavulanic acid. Once you add amoxicillin and clavulanic acid, this becomes broad spectrum because now you cover gram-negative and gram-positive, but not MRSA. Okay? Ampicillin is the same way. If you add ampicillin and sulbactam, you get unicin. Unicin becomes it becomes a broad spectrum antibiotic that covers gram-positives and gram-negatives, but does not get MRSA. All right? And just like the gram-positive side, we also have a big bad wolf in the gram-negative sides, and that's Pseudomonas aeruginosa. This is a terrible bacteria, and it needs bigger guns, and that bigger gun penicillin is called piperacillin. So if you're thinking that your patient has Pseudomonas, you will need piperacillin, and the beta-lactamase for piperacillin is called tazobactam. So if you combine penicillin and tazobactam, you get gram-negative coverage, including Pseudomonas, but does not get to MRSA. So, what I mean by this is if you need to destroy all gram-negative bacteria, you need to get Zosyn or piperacillin plus tazobactam. If you need to destroy all gram-negative bacteria, but you're not worried about Pseudomonas, then you need unicin or ampicillin sulbactam, or amoxicillin clavulanic. If you chose peptazone, it did not work, or the patient can't take it for any reason, there is a bigger gun that's very expensive, and that is the carbapenems. And those are things like meropenem or cardapenem, or all the other penems. All right, let's talk about the cephalosporins real quickly. The cephalosporins go from generation 1 to 2 to 3 to 4, and now we have a fifth generation. And they basically start out as more gram positive in the first and second generation. Third generation can do it all, minus and positive, gram positives and gram negatives. Fourth generations, now you're only talking about the gram negatives. Okay, so things like Keflex or cefazolin or things like that, they basically treat skin infections such as strep or MSSA. Remember, because MRSA, you need to come up here and deal with MRSA. But MSSA and strep skin infections, you can reach for first or second generation cephalosporin. The third generation cephalosporins like ceftriaxone, ceftazidime, will basically treat gram positives and gram negatives. Fourth generations like cefepime can deal with things like Pseudomonas, for example, if you're worried about things like that. So cefepime will treat Pseudomonas. You will have to remember that cefepime treats Pseudomonas. And that's basically all you have to remember for the cephalosporins. You need to remember that the third generations are used for gram positives and gram negatives. First and seconds are gram positive. And fourth generation is basically Pseudomonas and gram negatives. All right, the fluoroquinolones. Do not give to older people. Do not give to young kids. First, second, third generation. First generation is ciprofloxacin. Second generation is levofloxacin. Third generation is moxifloxacin. First generation treats gram-negative infections. So you hear ciprofloxacin being talked about like the urofluoroquinolone. And uro for UTIs or any, because most UTIs are gram-negative infections. And this is why this is the urofluoroquinolone. Moxicillin is gram-positive and generally referred to as the respiratory fluoroquinolone, because most pneumonias are gram-positive, strep pneumoniae or staph aureus. Levofloxacin is kind of in the middle and nobody really uses, but sometimes it can be used in pneumonias in certain extents. But I want you to remember first and third generations, not so much second generations. For the anaerobes, very simple. Infection in the vagina or the belly, use metronidazole. Anywhere else, use clindamycin. Very simple. Vagina, belly, metronidazole. Anywhere else, clindamycin. We'll quickly go through clinical scenarios and things that are just remembered. You just have to remember them. CAP is community-acquired pneumonia. Community-acquired pneumonia, you're worried about strep, staph. Staph we already discussed, MSSA, MRSA. So when you're talking about strep or staph, or were you talking about pneumonia, strep is the most likely cause. Strep pneumonia causes about 90% of all pneumonias. And so from the fluoroquinolones, the respiratory quinolone is the one that you'll most likely reach for. And so the guidelines specify moxifloxacin that can be used on its own, or which one of the cephalosporins can we use? We're looking for gram-positive coverage. We can use the third generations, and so you can use ceftriaxone, plus azithromycin. We didn't talk about the macrolides because they're not generally used very much, but this combination you should memorize. Ceftriaxone, azithromycin is generally used for anti-inflammatory purposes like in COPD, also in community-acquired pneumonias. Also, you can just use azithromycin on its own. And this you should use in patients who are who have pneumonia but are okay. They're walking and talking and have very little symptoms. So if they're doing okay, you want to go as narrow as possible. Try azithromycin and see what happens. If they get worse or they're not improving, then admit them and try this or this. Cool? Hospital-acquired pneumonia, you're basically now talking about Pseudomonas. Or MRSA. Sorry, I kind of blanked out there. So in this scenario, we already talked about MRSA. MRSA, you're basically gonna reach for the big guns, right? When you're talking about MRSA, you need to come up here and look for the big boys. And so we're gonna reach for vancomycin. And then for the Pseudomonas aspect, we already talked about Pseudomonas. And for Pseudomonas, you're going to need the bigger guns, which we talked about, and that is peptazo or unison. So you will need to reach for piperacillin and tazobactam. Or the 4th generation, cephalosporin, cefepime. Let's talk about meningitis. In meningitis, strep pneumoniae, in the elderly, you are talking about like things like listeria. You can talk about staph sometimes. And so let's just take it one at a time. Pseudomonas pneumonia, what can we do for it? Here's 3rd generation cephalosporins, which can do gram-positive stuff. So ceftriaxone. Listeria is a gram-positive, gram-negative infection. So we can use one of these simple gram-negative infections here, ampicillin or amoxicillin. Generally, ampicillin is better for listeria. And then for meningitis, you also sometimes want to try steroids. Actually, almost all the time you need to try steroids. And for empiric coverage, we also add vancomycin. And so if you get a person with meningitis, you want to give them vancomycin. You also want to give them ceftriaxone and vancomycin. You want to add steroids. And if they're immune compromised, you want to add ampicillin. Okay? UTI, we're basically here talking about gram-negative infections. Things like E. coli and things like that. And so we already talked about the gram-negatives. The simple gram-negatives, we go to amoxicillin or ampicillin. And so we'll try amoxicillin. Generally better for UTIs. You can also use Bactrim or trimethoprim sulfamethoxazole. You can also use nitrofurantoin. You can also use ceftriaxone. Remember, we talked about ceftriaxone being positive or negative. I'm sorry, this is starting to get very messy. You can also use ciprofloxacin. We talked about ciprofloxacin being 8 gram negative cover. And so now the question is, when do I choose, which one do I choose at what time? Simply, if your patient is pregnant, use amoxicillin. If not, you can use one of these two. If your patient is admitted in the hospital, use ceftriaxone. Actually, you can also use this with these. So ciprofloxacin, nitrofurantoin, or trimethoprim, sulfamethoxazole you can use. But this is generally used for patients with pyelonephritis that are okay, do not need to be admitted. And so if you have somebody with severe UTI and pyelonephritis, but they're okay, they're able to go home, then send them home with ciprofloxacin. If it's just a simple UTI, just Bactrim or nitrofurantoin. Bactrim, you have to be careful. If they have kidney failure, do not give them Bactrim. Nitrofurantoin is generally safe. Amoxicillin if they're pregnant. Okay? Cellulitis, basically staph and strep. If they have abscess formation on their skin, it's probably staph. So staph causes abscesses, strep, no abscess. Meaning if the leg or the arm or whatever the area of cellulitis is just red and no abscess formation, you're probably dealing with staph or strep, sorry. If they have a little bit of abscess formation and some bullae, then you're probably talking about abscess formation from staph infection. Either way, they're both gram-positive infections. And so gram-positive infections, let's come up here, let's say the cephalosporins. We already talked about cephalosporins, first and second generations give you skin coverage. So you're probably talking about Keflex, for example. But they're so severe, they can't go anywhere. Cephalosporins, you can pick ceftriaxones for IV. Oh no, we got cultures and they're MRSA. They're not MSSA, they're MRSA. We can go Vanco. No, they can't do Vanco. We can go linezolid. Alright, they went linezolid and now we're gonna discharge them. What can we send them home with? Bactrim, SMX, Doxy, or Clinda. These are antibiotics that treat MRSA, but are PO pills. And I'm sorry, this got very, very messy, but and this obviously isn't all of the antibiotics, but this should give you a good framework on what to reach for and what time. And remember, the goal of antibiotics is to try and get as narrow as possible. So think about the infection where it is it gram-positive, gram-negative, and try and be as narrow as possible before you get up here to the big guns. Okay, and thank you for listening.